Endoscopic hemostasis of diverticular hemorrhage in a colon conduit using an over-the-scope clip. Colon interposition is frequently used as an esophageal substitute in esophageal reconstruction. Few case reports have described the development of diverticular disease within the colonic conduit. To date, hemostasis of diverticular hemorrhage using an over-the-scope clip has only been described in a case of duodenal diverticular bleed and 2 cases of colonic diverticular bleed. Herein, we describe a previously unreported case of diverticular hemorrhage within an interposed colon with hemostasis using an over-the-scope clip. A 64-year-old female with a remote history of esophageal adenocarcinoma underwent Ivor-Lewis esophagectomy. Several years later, she was found to have gastric adenocarcinoma, for which she underwent total gastrectomy with colon interposition. She subsequently underwent Roux-en-Y surgical revision due to symptomatic bilious reflux. A year later, she presented with hypotension, hematemesis, melena, and acute anemia. She was on no antithrombotic therapy. Once medically stabilized and intubated for airway protection, she was referred for endoscopy. The proximal esophagus was grossly unremarkable, with the esophageal anastomosis at 23 centimeters. Just below this anastomosis, a single diverticulum was seen with an adherent clot. Careful inspection of the remaining conduit revealed no other bleeding lesions. The colojejunal anastomosis was at 40 centimeters and showed normal post-surgical limbs. Using a distal attachment cap for better visualization, the diverticulum was re-examined. After lavaging and suctioning the adherent clot, active bleeding was noted. The gastroscope was then fitted with a T-type over-the-scope clip. The bleeding diverticulum was then suctioned into the application cap, and the clip was deployed without difficulty. Careful inspection revealed complete tissue approximation and hemostasis. After endoscopy, she was observed in the hospital and discharged on post-procedure day 3 without signs of rebleeding. Definitive management of diverticular hemorrhage traditionally has been endoscopically managed with epinephrine injection, multipolar electrocoagulation, hemoclips, and rubber band ligation. In this unique case, over-the-scope clip was felt to be more advantageous than these traditional options. The vasoconstrictive effects of epinephrine would have likely been insufficient to overcome the brisk, pulsatile bleeding of this case, and at most would offer only a transient effect rather than definitive hemostasis. Due to the active bleeding, which limited visualization, there were no clear targets for electrocoagulation therapy. Moreover, the increased risk of perforation with this modality was a risk that had to be minimized, as a perforation may have required major thoracic surgery for repair. Given the limited tissue approximation of hemoclips, multiple clips would have been needed, and a misplaced clip could potentially obstruct access for subsequent clip placement. While band ligation employs similar mechanism for hemostasis, over-the-scope clip offers a slightly larger circumferential tissue approximation. Endoscopic management is preferred to the second line of management of vascular embolization or surgery, which is particularly important in this case with an intrathoracic culprit lesion. Diverticular hemorrhage should be considered in the differential for upper GI bleeding in patients with a history of colon interposition. Over-the-scope clip may be a more appealing hemostasis option given better mechanical compression and larger tissue approximation.